Okay, good afternoon. I want to thank the Planning Committee for the opportunity to speak here. And I kind of boiled down my somewhat lengthy title to the newborn consult, okay, because they are such delight to have. And here are my financial disclosures, none of which pertain to the content of this presentation. So as a glaucoma specialist, when I get a newborn consult, the question is pretty simple. Usually it's a baby that is born with congenital corneal opacity in one or both eyes, or when the cornea is clear, when they have cupping. And the question to me is this glaucoma, and what do I do? Okay, so I'll go over my approach when I encounter these two entities. And it's important to remember that in 2013, the World Glaucoma Association and Childhood Glaucoma Research Network has come together and formulated a very comprehensive diagnostic criteria for childhood glaucoma, which can really guide our decision making. So on to congenital corneal opacity. The scenario usually is an urgent referral by either a neonatologist or pediatric ophthalmologist, and the evaluation will be a baby who has congenital corneal opacity in one or both eyes. In these cases, it's important to determine the mode of delivery to raw birth trauma. In eyes that present with congenital corneal opacity that actually has congenital glaucoma, typically you would see diffuse haze as opposed to localized haze. And the limbus lends a clue also, and they will look kind of indistinct and stretched out. Often there's microcystic edema, and the corneal diameter will be enlarged. And onto the diagnostic criteria here. In this case, the pressure really gives one-sided information. When you have a edematous cornea, if the pressure measures high, it usually is. But if the pressure measures normal, you don't know. And optic nerve findings typically are not helpful because there's typically no view to the back of the eye. So we're relying on the presence of Hobbs striae or increased diameter to help us make the diagnosis. So how do we estimate corneal diameter? Here are my two children when they were newborns. And the white-to-white corneal diameter should be 9.5 to 10.5 at birth, and then the horizontal palpebral fissure is somewhere around 18 millimeters. So for most children, when they AD or AB duct, you should be able to see at least some white, up to about a third of the horizontal palpebral fissure, like this. And also note the color change between the sclera and the cornea should be very abrupt. The limbus should be very well demarcated. In contrast, this is a child with primary congenital glaucoma. You can see right here that you see very little sclera even in adduction. And over here, the limbus is quite indistinct, and the color change from the sclera to the cornea is much more gradual. And in these cases, I find it helpful to start presumptive treatment with IOP-lowering medication, because if the cornea then clears up with the treatment, then you have proved to yourself that there's some IOP-related edema. However, if the cornea remains hazy, then the test did not give us the information that we want. Ancillary testing is very important, and the three modes that I use mostly are anterior segment OCT, ultrasound biomicroscopy, and I use B-scan to assess cupping. In this particular case, the right eye is a normal eye with a clear cornea, can see normal globe size, and there's no cupping at the disc. The fellow eye has a densely hazy cornea, enlarged globe, and right here is significant excavation of the optic nerve head. How about this case? Really borderline. There's a generalized haze in the cornea, but not too bad. Pressure is in the low 20s, and there's this strange white band over here. And when we scanned this using anterior segment OCT, we then realized that this was indeed an evolving Hobbs striae with the leaflets of the broken decimates hanging over there, and this child has glaucoma. In contrast, we have this case where the opacity is very localized to the center. Corneal diameter is normal, and there are clear areas in the cornea. And when we did ultrasound biomicroscopy, we see some kind of strange stalk adherent to the back of the cornea. And when we image this through the clear areas, we notice that there is keratolenticular adhesion, and this was in fact a type 2 Peters anomaly and not glaucoma, at least not yet. How about disc cupping? So we're approaching a child with a clear cornea, but there's disc cupping. The scenario usually is a less urgent referral by a pediatric ophthalmologist or a retina specialist, usually after ROP rounds, because there's usually no other good reason to want to do a dilated fundus exam on an otherwise healthy newborn. And it's important at this point to figure out how preterm they are, because in preterm children, especially those with a history of intracranial bleed, they can have enlarged cupping due to optic atrophy. And in eyes that have congenital glaucoma, typically the corneal diameter will be somewhat enlarged. Sometimes you can see Hobbs striae, although these could be very, very faint. And often they have increased axial length. You can measure this by A scan, but in the clinic, what I find to be a good marker would be axial myopia. And you should pick this up by retinoscopy. So again, with the diagnostic criteria, pressure in this case is a little bit more helpful because the cornea is clear, you can believe what you're measuring. We're dealing with cupping, and so we're relying again on the presence of Hobbs striae or increased corneal diameter, and as well as myopic shift to make the diagnosis. So this was a child who presented with cupping. I had a suboptimal exam in clinic, and I was able to determine that the child had a certain amount of myopia just because my retinoscopy streak kept on going against when I know in the baby it should be with. And on exam, under anesthesia, we noticed that there's a very, very faint Hobbs striae going through the center. And it turns out that this child indeed had congenital glaucoma. So in summary, when you're approaching a newborn consult with either congenital corneal opacity or disc cupping, corneal diameter and the presence of Hobbs striae lends a clue on whether or not this is glaucoma. And some helpful tests includes a provocative test with the IOP lowering agent, in that if the cornea clears, then you know there's pressure-related damage. And ancillary testing can be helpful. Most importantly, always remember to refract children with clear cornea and cupping, because pathologic myopia is one of the markers of glaucoma. Thank you very much.
Okay, can we have Dr. Chang's ARS question back up, please? All right, so I'll give everyone a chance to answer the question and see if the content of his talk changed your answer at all. All right, a little bit, sure. Okay.